Great. Good afternoon, everyone. We're just going to give it a couple minutes for everyone else to join us. Good afternoon, everyone. We're just going to give it one more minute and then we'll get started. Okay, everyone. Good afternoon. My name is Frank McStay, and I'm the Assistant Research Director for Medicare Accountable Care Transformation. I appreciate everyone joining us this afternoon for our specialty webinar focused on strengthening whole person specialty care through accountable care innovation. We have a very ambitious agenda to get through today. Just to take care of a couple housekeeping items before I kick off and walk through the agenda, first off, I just want to note that the Q&A is open and we will try to get to questions and answers as we are able, and we will try to follow up with folks afterwards as well. Secondly, I do want to acknowledge the folks that have made this event possible. First of all, West Health and our collaboration with them to advance and accelerate value-based payment reforms in the United States health system. They've been a tremendous collaborator for many years with us and appreciate all their support. Secondly, again, I want to appreciate the people that actually helped us make this webinar happen, including our panelists, who we'll meet in a minute, as well as the folks at Duke-Margolis, including Mark Jappinga, Rachel Bonesteel, Sarah DeBev, Hannah and Luke, as well as Dr. Saunders and Dr. McClellan for all their support. So for today's agenda, I'm going to kick off with a few slides, but I'm going to get through those as fast as possible so that we can immediately move into a fireside chat with our folks and colleagues at CMMI. We're then going to move into a moderated discussion with Mark Jappinga with different innovators that we see from around the accountable care space in the commercial sector. And then at the end, we're going to wrap up and have a couple key takeaways from our conversation this afternoon. So with that in mind, where I want to start off is first by acknowledging this framework that Duke-Margolis put out at the end of last year that kind of helps us conceptualize where the big buckets of specialty care reform and specialty care payment models in particular are occurring. We see on the left side of the screen the whole person specialty care model, where we often see very advanced and complex patients where the specialist more or less manages the entire care for the person and the population. We then move into the acute episodic specialty care. These are often those acute medical events and procedures where it's a fraction of the whole person's care, but an important part of the whole person care that is led by the specialists. The third that we're really interested in talking about today with you all is the longitudinal specialty care bucket, where we talk about that integration and that co-management piece with primary care. Again, this piece was put out by Duke-Margolis last year, and we'll provide a link to it in the chat for you all. As we probably all know and was linked to in the registration event for this event, CMMI recently published a continuation or an update to its specialty strategy that it put out in November 2022. Across these four big areas that we're going to be talking about and that CMMI recently updated are strategies that the agency is pushing out to ensure that we continue to advance the next iteration of specialty care integration with primary care, as well as those acute bundles and those whole person models of care. We're going to be talking a lot today, mostly about initiative number 1 and initiative number 3, but encourage people that have not had the opportunity to read the updated blog that was published this week in Health Affairs to go do so, because it contains a lot of new information as well as some updates to existing information about where the agency is heading with its specialty strategy. I think a big key takeaway beyond our focus of longitudinal payment models is that, and as the panelists and I were just discussing, there's a lot of focus right now on how do you better engage specialists as well as incorporate specialists into new accountable care arrangements. This includes the update that I just noted about CMS and their focus very much on that data infrastructure as well as those new models of care, as well as improving upon the BPCIA initiatives that are foundational to help on-ramp specialists into accountable care. We've heard a lot from commercial payers, and they've made known that they're very focused on that longitudinal care piece where they're trying to better integrate specialty care with primary care, including putting out new initiatives that are on subcapitated arrangements, as well as improving integration into their existing ACO models. Accountable providers are also leveraging their internal data and other accountable care elements to help reduce specialty care spending and improve co-management with their primary care partners. This includes exploring high-cost drugs, as well as reducing variation in practice patterns, again, with the idea of improved longitudinal management and co-management of patients. With that in mind, I would like to move straight into a discussion with our colleague Sarah Fogler at the Centers for Medicare and Medicaid Innovation. I'll stop sharing my screen. Sarah, it's great to have you with us. First of all, I want to acknowledge again, appreciate your time, but also the time that you invested in the recent blog that you put out about your specialty care strategy update. And I think that's where I'd like to begin, is just give you an opportunity to talk about what that blog contains and kind of that strategy update from CMMI.
Yeah, and thank you so much, Frank, for the invitation. I'm so excited to present on this body of work. We have been actively and deeply steeped in opportunities for improving specialty integration for the last, looking back a decade, certainly in our episode-based payment model work and some of our condition-based models that focus on oncology and kidney. But we've refreshed our thinking and recognized that we need to, as you pointed out on your second slide, need to move upstream in some of our specialty integration work. And I think that's really at the heart both of what we published in November of 22, laying out this kind of strategy that was going to lay forward our path for the next 10 or more years here in terms of our work of testing new and different approaches to specialty integration. And then just recently, a couple of days ago, I think Tuesday now, the update on our progress towards those goals. I think a couple things before I dive into some of the updates, just for those that didn't have the opportunity to click on the link, maybe to kind of get caught up on where we are. We have 4 elements that we are focused on, and I can share updates on kind of progress on each of those elements today, although I'll hone in on 2 of those elements. And I just want to acknowledge, some of the things we could do pretty quickly, which I'm happy to report on some deliverables that we've, just released this year to advance our specialty care integration goals. And some of the strategies and the development work is longer term. And so we're actively in design conversations. But what's really nice about the strategy, aside from being, cutting across the patient care continuum more so than we have in the past, is that there's this iterative development and release of strategies, new model tests, tools that all kind of are aiming to get providers and accountable care organizations and the agency rowing in the same direction in terms of specialty care integration. So really excited to be kind of reporting out today and happy to go kind of element through element. Frank, if that works.
Yeah, that would be great, especially that first element, that data transparency. I know CMMI has really focused a lot there recently, so it'd be great to maybe focus there first.
Happy to. So element 1, just as a quick reminder, is not a specific model test. Instead, it's a commitment that we've made to improving data transparency around specialist performance. And obviously, the hope with increasing data transparency is that we'll be able to drive more informed partnerships between providers that will lead to lower cost and improved quality for beneficiaries in the longer term. So the 2 updates I have to share today, some are in the blog and some are more kind of foreshadowing what the future holds here, is that 1, in February, we delivered our first set of shadow bundle data files, and I'll define that for you in a minute. But before I do, I want folks to know that we have delivered this kind of data package to accountable care organizations participating in the Medicare Shared Savings Program, and also the Realizing Equity, Access, and Community Health, otherwise known as REACH ACO model. These shadow bundles are modeled after our bundled payment for care improvement initiative that I think you made mention of in your opening remarks, where we construct episodes of care. So upon hospital discharge, 90 days thereafter, we construct an episode-based target or a benchmark. And, we work with hospitals and physician group practices we have in the past on trying to better manage the episode of care. And that's primarily come down to, at the practical level, like doing a better job managing care transitions. So we're avoiding readmissions. And so now ACOs will be armed with information on their ACO attributed lives for those folks that are triggering up to 34 medical and procedural episodes, so that they can better understand how their attributed beneficiaries are moving through an acute procedural medical event and what the thereafter 90-day period looks like in terms of cost and quality. And, again, the spirit of sharing this increased data transparency is that there's greater ability to kind of target where your best practices are, to identify where you might have opportunities, and feed some of these partnership conversations between primary care ACO entities and their specialty care partners. So those files have just been released in February. They will be released monthly in terms of like claims line data, and then we'll summarize them in dashboard form. And we have a series of feedback sessions scheduled so we can understand how ACOs are using the data, if it's helpful, if we need to do revisions, et cetera. And this, even though we've made the first delivery in February, we already have kind of phase 2 under development, which is contemplating moving beyond just the acute medical procedural episode data sharing into the chronic space. So considering sharing episode-based cost measure data with ACOs too, that will provide greater insight on specialist performance as well. So look for that, I would say, next year's time.
And I know, kind of like you were mentioning, that there's going to be iterative updates to the specialty data or the shadow bundles, that you all engage with a lot of ACOs preemptively to figure out, one, what they needed, but two, what would be most actionable for them and what would kind of make the most impact right now. To that end, I would like to hear, the blog talks about what could be next for this beyond iterative feedbacks and kind of improving upon the shadow bundle information itself. But what is kind of that next step that you're thinking about with data transparency?
Yeah. So we'll definitely include episode-based cost measures in that future state bucket. The other thing that I'm happy to report out on is that we are also preparing additional data to be included in our model participant dashboards. So let's talk a little bit about our interest in helping primary and specialty care providers work better together. We have a new model that we're launching, actually a primary care model, July 1 of this coming year. That's referred to as the Making Care Primary model. And it's really, for lack of a better word, our pilot test of incorporating additional specialty care data into their data dashboards. Again, in the spirit of providing more information for primary care physicians to understand how their attributed beneficiaries are experiencing specialty care, and for them, those primary care practitioners, to identify potential specialty care partners. So they will get information not only on how their ACO attributed lives are moving through specialty care, but they will get information on performance, utilization, cost, and some quality on specialists in their market on all fee-for-service beneficiaries. So if they want to shop around for a stronger specialty care partner, they would be able to with that additional information. So that the model will launch in July. There'll be some early specialty care data included there. That data will become more robust in the following year. We'll go through that same similar feedback cycle. And then on the horizon is moving beyond just MCP into other models that the Innovation Center is testing, and potentially even to CMS programs like the Medicare Shared Savings Program as well.
That's exciting to hear, because you guys all you've launched a lot of models recently. And so there's definitely an opportunity here to provide more of that data to a larger audience to really improve that kind of integration that's so foundational to not just chronic disease management, but also exactly what you're talking about, just better integration with their primary care colleagues. To that end, I do want to get to element 3, where we talk
Yeah.
about financial incentives to really kind of better integrate and incentivize collaboration among primary care and specialists to drive engagement with specialists in accountable care models. So turning the floor to you, would love to hear more about that element 3 in both the short term as well as kind of that long-term arc for what we can expect.
I mean, personally, I think element 3 is one of the most powerful features of the specialty care strategy. And the reason is we have been so thoughtful based on tons of conversation and interviews with healthcare operators, with policy experts, with beneficiaries, with providers. And what we ultimately learned may not seem to an aha moment to everybody on the call today, but what we ultimately learned is it's not enough to provide incentives on one side of the equation. And what I mean by that is we've been long committed to the investment in primary care, advanced primary care movement. In those models, we have advocated for, primary care physicians to engage their specialists to community so that their attributed beneficiaries could receive kind of whole person care, including specialized care needs. What we didn't have active in our previous model tests with primary care is actual incentives for the specialists to want to partner with the primary care physicians. And so to some degree, we encouraged it, but we didn't kind of put the dollars behind it and heighten its importance in actually delivering improved patient outcomes. So what I really love about element 3 is it's two-part. It is about launching a new primary care model, the Making Care Primary model I already referenced this July, that has explicit specialty care strategies in it, integrative specialty care strategies. Things like building out collaborative care arrangements between primary care practitioners and specialists. The data sharing that I mentioned in the previous under element 1 we're hoping will feed some of those smart partnership decisions and ability to kind of target what specialists in any given market are doing a good job on managing chronic conditions that the primary care physician might want to partner with. So there's new data, there's examples of how to establish collaborative care agreements. There are new codes available for specialists to bill for co-management of chronic disease. So in the event where a primary care physician really is struggling to get a beneficiary to have stabilization of some chronic condition, having a partner, a specialty care partner they can call on to really stabilize and get that beneficiary on a care management plan that's both informed by primary and specialty care. So there's dollars behind our interest in testing this primary care model, again, that has an explicit specialty integration feature, several specialty integration features. But as I said before, recognizing that only trying to move through primary care practices to get to specialists has not been sufficient. We haven't seen the outcomes we're looking for. Fragmentation is increasing. Beneficiaries are seeing more than 20 providers in a given year, right? Like there needs to be some better management here. So we are planning to complement, and that's a really important word that I'll come back to. We're planning to complement the primary care model that we're going to be testing with a new model concept that's really targeting the ambulatory specialty care practices. And so roughly we've been talking about this concept as a ambulatory specialty care concept that would look to, again, complement MCP, but directly engage specialists in meaningful value-based payment. And it would increase the number of primary and specialty care arrangements and do so in a way that maximizes impact without creating more burden or complicated overlap issues that we've struggled with in the past in terms of like who's responsible for any given beneficiary at any point in their care journey. So let me say a little bit more just roughly about what we're thinking about in terms of this model design, but I would call your attention. We are going to be releasing an RFI, a request for information, for public comment on some of our early thinking about how we would want to construct a model design in this space. There's a couple things I would just call out though for early awareness. One is that we see the MIPS value pathway reporting option as a framework that could really allow us to kind of rapidly do some work in this space, to better engage specialists in value-based care and do so in a way that complements our energies in the Making Care primary model. So the MIPS value pathway reporting option is pretty new, only a few years in operation, but it's a promising mechanism to engage specialists in both upside and downside risk. It presents, an opportunity to drive a range of clinicians of various specialty types into value-based care, flexibly accommodating to unique clinical scenarios. So there's 4 components of each MIPS value pathway. There are specialty-focused quality measures, there's improvement activities, there's CMS calculated cost measures, and a focus on interoperability. The idea here is that the model would leverage the same payment methodology that's used currently by the MIPS MVPs, but with some changes. And we are in, as I currently said, the early stages of model development here. We're exploring some of what those changes might look like, but a couple things that I would just make note of, lessons learned from early implementation of the MVPs. We like that it's a pre-existing methodology, but we recognize there are some items we might like to tweak under our statutory authority to kind of design some new innovative service delivery and payment mechanisms. And we're thinking about starting with some certain specialty types and conditions. So there are, I think, up to 16 MVPs now that are condition specific. I think we're interested in looking at some of the orthopedic ones. We're interested in cardiology. We've talked a little bit about pulmonology. So we'll be looking for tons of feedback. We're interested in public opinion on how we might start and how we might advance the work on this ambulatory specialty model concept moving forward. So in summary, I love the relationship between these 2 different strategies under element 3, which is pulling levers in primary care, but also pulling levers in ambulatory specialties so that they're complementary of one another and we get folks rowing in the same direction towards value-based care.
Yeah, and I think one that really meets the goal of engaging the specialists, but also the other goal of kind of reducing burden and doing it in a meaningful way. So it's not hard, it's not new. It uses kind of existing infrastructure, existing knowledge, but improves upon it, kind of like what you've done with your specialty strategy more broadly of allowing for meaningful partnerships and dialogue, but really allowing for a very practical short-term steps to improve upon, for example, like the MVPs.
And one more thing on that, Frank, sorry, I don't want to lose the opportunity to make this one point. What I love about the MVP structure, I mean, certainly it's in early years, and as everyone knows, our policies iterate over time as we learn what works and doesn't work. But one of the features I really like about the MVP construction is that when a primary care physician does well, the specialist does well. When a specialist does well, the primary care physician does well. So it's a wonderful, from my perspective, measurement tool of the integration, because you're really rewarding both providers for the shared outcomes of a single beneficiary, which is what we've struggled with a little bit in the past with our models where there's overlap and, co-management is needed in some occasions, and multiple providers should be incentivized to deliver better outcomes for that beneficiary. And I think this strategy helps us move in that direction.
Agree. Yeah. I know we're almost out of time. Would like to just kind of turn the floor to you. I know there's a lot we could talk about. We really didn't get a chance to talk about some of the condition-based models, such as Guide, that have come out. And we didn't talk about element 4. We're talking about population-based or specialist engagement in population-based models beyond kind of the elements 1 and 3. So would turn the floor to you in the last remaining couple minutes, especially on those 2 points of condition-based models and engagement population-based models. What should folks be paying attention to or thinking about with the CMMI strategy?
Yeah, thanks for the opportunity to kind of weigh in on the other features here. So we remain very committed. Most of our work has been in the episode-based payment space work and the condition-based management work, at least in the group that I manage. The Innovation Center has certainly been interested in ACO since day one, and primary care, but we remain very committed to better episode-based care management. And we've done more than a decade of testing with the comprehensive joint replacement model, with the bundled payment for care improvement initiative. to really do a better job on managing spend and reducing waste and preventing readmissions, having really solid care transitions. And we're still committed to that. So I would say look for some new information coming forward in through the rulemaking cycle, the fiscal year 2025 IPPS rule, the NPRM. So look for more information on our future plans for the bundle payment work there. As you noted, we have a new dementia care model that will launch July 1 of this year as well. And on element 4, which is really about supporting ACOs in the integration of specialists as well, I would say that is a longer term milestone intentionally, because we want to learn from elements 1, 2, and 3 about how our strategies that we're testing in those can inform that longer term strategy of supporting accountable care organizations and total cost of care, total population management. So more to come on that one, but I hope that's a helpful summation.
It really is. And I just want to thank you for one, that blog is tremendous. Appreciate all you and your colleagues are doing at CMMI to improve specialty engagement in value-based care and accountable care payment models. And appreciate your time and coming to stop by with us today about the update and about all you're doing. So Sarah, appreciate it again. And it's now my pleasure to introduce Mark Jappinga for a really thrilling discussion about kind of that strategy and how different folks are thinking about the co-management piece and that longitudinal payment model piece. So Mark, over to you.
Thank you, Frank, and thank you, Sarah, for joining, and thank you for all in attendance today. I'm Mark Jappinga, excited to take the baton to talk about all of the different moving pieces happening across healthcare to engage specialists in accountable care models. So I think as you heard, CMMI rightfully sets the tone for all of this. The initiatives we talked about today, strengthening data infrastructure, improving engagement and coordination. These are the foundational elements of any accountable care model. But I think it takes a village to make progress in healthcare policy and ultimately have real impact for patients. I think this is especially true as we start to expand the guardrails for what specialty reform covers. And as Frank pointed out in the end, start to think about these condition models for longitudinal specialty care. I think the easiest example is that we've gotten really good at improving joint replacement surgeries, but how can we improve the kind of care that might prevent that surgery from happening in the first place? How do we know what that kind of high value specialist looks like? So we at Duke released a paper laying out a vision for these types of condition-based models back in 2022 and continue to work on this issue today. I think what I've really learned in this process is mostly how much there still is to learn. But what excites me about it is how CMMI and our panelists today are facing these challenges head on. Without further ado, I want to bring in our panel today. We have Erica Everhart, David Johnson, and Nina Birnbaum, who are each approaching and thinking about these issues in a different way. I think that starts with data, and I want to start with our panel by asking kind of the way each of our panelists uses this data, because I think it's a great example of their unique roles in the system. Welcome to all of you, and I want to start with Erica. Feel free to introduce yourself and talk a bit more about how data is driving the work that you do.
Great, thank you so much. And also thank you for having me today. And I also want to take a second to echo Frank's thanks to CMS for all of their work in specialty care. I'm Erica Everhart. I am with Care Journey. My title is Head of Thought Leadership, which means I get to put my hands on a lot of different complex problems. And one of the things I've been spending a lot of time working on is specialty care and how we can integrate that into a value-based care ecosystem. So at Care Journey, we use the logic from the episode grouper for Medicare, tweaked a little bit, and we layer that over claims data to create hundreds of risk-adjusted episodes. And we do both commercial and Medicare claims data. We have the acute episodes, including those BIPSI episodes that Sarah was talking about. And we also have a set of chronic care episodes that are year-long episodes. We look at these episodes by provider level, practice group level, and facility level. And then we analyze them along both cost efficiency and several quality measures like complication costs, unplanned readmissions, ED visits, and things like that, to see where we can find variation, both in the cost and the quality of these episodes, which of course are very intertwined. Sometimes we see depending on the episode, sometimes we see Part B drugs as the differentiator. Sometimes it's like complications like sepsis or procedures that some providers do and others don't. Sometimes it's like SNF utilization. So right now we're taking all of that data and we're putting it together, and we share it with ACOs, with providers, employers, really anybody who's looking to understand what's happening within their population from an episode perspective, and whether there are inefficiencies that they can correct for.
Thanks, Erica. I want to bring in Nina next because I think the work that Erica does and the work that a big payer do are similar, but you're going at it in different ways. Nina, thanks for joining us today.
Oh, thank you so much for having me. I just want to echo what Erica said. It's just really an honor to be here. So I'm Nina Birnbaum. I'm a family physician, still practicing in primary care just a little bit because my day job is I'm the medical director of innovation acceleration at Blue Shield of California. And sort of similar to Erica, I get to put my hands into all kinds of cool and interesting things, but I do serve as the clinician advisor to our value-based payment group at Blue Shield. And our specialty payment strategy right now is really focused on the episodes of care, the procedural episodes, because that's sort of the place to start. Clear, data is much easier to pull and to limit. And we've found some really interesting things already working in there. It should be easy in a short procedural episode to see what's in and what's out, and the boundaries are clear for the most part. But we've had the issue to me is using data to engage clinicians. You want to have that through line all the way from the payer to the institution to the individual clinician or physician making decisions. And we had a great example in one of our ortho bundles of if there's a cancer diagnosis, it excludes the episode because that's going to be more complicated and therefore more expensive, and the physician should be held accountable to the cost in the same way. Well, this patient had the cancer that the patient had was a skin cancer, totally, not affecting the bundle cost or the complications of the bundle. And yet it excluded the data, the way it was processed, excluded the episode. So the physician actually came to us and said, hey, this doesn't make sense. Can you work with me? And so there's this fear that when you show clinicians their cost data, their quality data, their outcomes, that they're going to, push back and reject it. And sometimes they do at first, right? But the more we can really have data-based engagement of clinicians, I think we'll start to pull them into the conversation and start to really see changes in the outcome.
Thanks, Nina. And I think that really sets up David well, because I think you're taking a lot of these principles, trying to go beyond the episode, try to work with providers, and that's informing the work that you're doing at Rubicon.
Yeah, thanks, Mark. Again, appreciate the invite to speak today. So David Johnson, I'm a practicing urologic oncologist around the corner from the Duke-Margolis team in Chapel Hill at UNC. Also, my day job is clinical operating partner at Rubicon Founders. We're an entrepreneurial investment firm located in Nashville, and our mission really is to build and grow transformational health services companies that deliver sustainable value to the broader healthcare system. And we clearly have a very strong value-based care slant and sort of DNA of the firm, and also are very focused on specialty care and engaging specialists. Prior to joining Rubicon, I was actually on the payer side at Blue Cross of North Carolina, doing similar payment design work, trying to get specialists engaged and incentivized in alignment with a lot of the PCP ACO models that are out there. So at Rubicon, data really is the foundation to how we approach designing and launching new transformational companies. Similar to the care journey approach, we look at specialty areas kind of horizontally and then dig deep into different cost categories. Where is the problem area? What's the scope of the issue? Where do we see variation in outcomes and utilization? What drives excessive costs and suboptimal outcomes? And sort of define the problem using data. And that really sets the foundation for determining what the solution is from a clinical lens. So what care models are evidence-based? What does the data show us in real world evidence, moving beyond just clinical trials, which we know don't always translate to the real world? Who has actually deployed these types of models in the real world, and why have they not scaled? And really involving all stakeholders to understand why these care models that have delivered outcomes and are evidence-based and align providers with outcomes that really do matter to patients what is the barrier? And oftentimes it's the way, you know, the health system is financed. And so often payment models are the way to align those incentives and make it a sustainable business model to deliver the highest value care models to our patients. And really that's the foundation for launching and scaling our new companies.
Yeah, that's great. And I would love to talk a little bit more with all of you of kind of what that means in practice, because we lay out kind of a vision in our paper, and thank you, Rachel, for posting that in the chat, of these kind of neat, really long longitudinal models, as if we could just wave our hands and implement them tomorrow. But I think what we're really learning, especially with this data, is that there's kind of specific points or specific questions that you can ask, and maybe specific areas that you found where we can at least get people started and you know, help better understand sort of what a bigger model could look like in the future. And I'm kind of curious what areas you found to be you know, most promising, or what it takes to kind of, you know, really start building the foundation for that. Nina, can you talk about sort of what you think about as a payer level with that issue?
Yeah. Longitudinal models are a real challenge in specialty care. And I think it's our mental model, right? Like we have to shift our mental model. We've got that in primary care. You know, it's easy in our minds to attribute longitudinal care to primary care. It's what we do in primary care. And then we can lift that same model onto really complex patients, like the kidney care models, where, you know, someone who's got end-stage renal disease, essentially their primary care comes often from their kidney care doctor. And so, you know, you can sort of say that same thing. But looking at the specialties in the middle is a lot harder. So definitely in our work at Blue Shield in California, we're looking at single specialty longitudinal care models. Like cardiology is one that sort of, you know, people often see their cardiologist for many years over time, and the cardiologist clearly manages a portion of their care. Endocrinology can be very similar. But really the challenge on our end as a payer is when it comes to layering the longitudinal payment models. You know, we've got a decent amount of experience over a decade with ACOs, you know, kind of that's longitudinal care, attributed members. We've got that with primary care. We're really moving into value-based primary care. If we have physicians who are in that same ACO, primary care physicians who are in the ACO, and they're being paid in a value-based way, how do we bring the specialty care physicians under that same umbrella so that we're aligning all the incentives, from our end to the ACO, all the way down to all the individual physicians, so that you then get that through line, that people the payment enables people to shift their mental model to work together. Because often what that means, if you're paying someone more for value-based care, they have to change what they do. And when you're paying for fee-for-service, what that means is, how many appointments can I get on my calendar in a given day? Like, can I do it in 15 minutes? Can I do it in 10? You know, because that's your incentive. If you're paying in a value-based way, it might come to, how much time can I block in my schedule to call specialists or to call primary care doctors? And so it's getting that shift in the mental model by layering models is really it's the complicated piece that we're trying to grapple with.
Yeah, it's always struck me how many different ways there are into this issue.
Mm-hmm.
And Erica, I know you work with a wide variety of providers, and you're trying to ask these different questions too. Are there helpful ways to help you know, specialists understand, is like, all right, what specific thing am I trying to solve? Or how are we framing the question to know, like, okay, this approach is going to work better than what we've been doing before?
Yeah, so we work with a lot of organizations that are taking on total cost of care risk for their patients, and also shared savings, ACOs. And as they're trying to approach this idea of longitudinal models, or frankly, any sort of subcapitated payment arrangement, you can see the stress in their eyes as they start to talk to you about the logistics. And, you know, we can provide lots of data, and we can provide cost points, and, you know, a lot of data to help with making the decision on what you want to, you know, what are your biggest cost episodes that you could maybe steer, right? But there's still, like she was saying, it's really hard from a logistics perspective to align all of the incentives. What we've been getting a lot of interest in, which is something that we're working on pretty heavily right now, is actually going upstream of episodes. So when you're thinking about like longitudinal care, what we're looking at now is kind of like what's already happened. Like we know who's had spinal fusion, but like, should they have had spinal fusion? And so looking at, where patients fall down this pipeline and do they get sorted into the correct buckets, looking at rates of patients being routed to GLP-1s, by provider, or, benchmarking that within a market to see if there are outliers, looking at a patient who has obesity and the three options, GLP-1s or, dietary or bariatric surgery, like what is the preference sensitive care decision making that's going on. Can we derive any information about that from data, and sharing that with our ACOs? And we're also leaning into, we were talking about specialty specific episodes of care. We're also leaning into something that would maybe be more applicable to a primary care doctor who's serving as sort of a quarterback, but patient cohorts and chronic condition bundles that are multiple comorbidities like sleep apnea and heart disease. And so when you can combine things like this and understand treatment patterns combined with patient outcomes, that gives you a really powerful tool for things like plan design, network design, bundled payment programs. It has a lot of applications, but I really think the struggle is, that through line, that getting that data in an understandable manner to every person who's involved, so that everybody is sort of rowing in the same direction with the same understanding of why this data is being thrown at them, and how it ultimately helps not just, providers not that feeling that they have to just, up their RVUs, but they're actually, creating better outcomes and hopefully downsizing their stress level too.
Yeah, and I think this leads in well to the work that David does, because I think you've thought about this both from an area like kidney care, where it is a little bit more comprehensive and easier to manage, but then also how to expand into these spaces. And I was wondering if you could talk a little bit more about what you found as you've moved beyond kidney care, and how you're thinking about other conditions as well, and what you found so far.
Yeah, absolutely. I think we start with trying to figure out what is the most appropriate payment model construct for the type of care that the specialist is providing. And not every specialist or specialty episode is appropriate for a longitudinal total cost of care full risk model. But those that are those specialists that become the overall quarterback of care. And that really means different things for different people, but seeing the specialist, or what they're seeing the specialist for, is really the primary driver of their overall health. And then whatever they're seeing the specialist for is also accounting for a very high proportion of their healthcare expenditures. So, us, like everyone else, started in the kidney space. So we launched a company called Evergreen Nephrology that helped enable nephrology practices to take risk in the CMMI models, and also Medicare Advantage, and increasingly other lines of business, for total cost of care for patients with CKD 4 and above, and hopefully, again, moving further upstream as we get more sophisticated. In cardiology, our approach is a little bit more blended. We are building a value-based business unit within a community cardiology platform called US Heart and Vascular. And really the goal here is to figure out what fits better in a episodic type of approach that, more aligns with BPCI, or hopefully this ambulatory, specialty model. But then also, what are the models that for patients that the cardiologist does become the QB? So advanced heart failure, for example, that could be a condition that is more appropriate for the longitudinal total cost of care full risk model that we've been discussing. But it's not a one size fits all for everything even within a certain specialty. Again, with oncology, oncologists become the de facto PCP as well, so that's the optimal model for either patient or provider. But I think the payment constructs to date have really focused on a 6-month episode of systemic therapy. And that's not how oncology is, experienced by the patient. It's not how the relationship goes with the provider. And so we need to evolve to think about what is the best construct for patients with advanced cancer. This is something that waxes and wanes, that has periods of remission, survivorship, that has its own unique complications. It has progression, recurrence, and then considerations at the end of life. And that type of clinical care and that longitudinal journey does not necessarily just fit into an episode of active treatment. So it's a good building block, but I think we're trying to expand beyond those initial starting points.
Yeah, I think that's a good jumping off point to talk about sort of, I don't know, how do we add more building blocks, or do we have the right ones? Because we all love building things and infrastructure and the side of healthcare. And I think what we're discovering is when we ask ourselves, like, okay, what does a good specialist look like? We often don't have all the tools we need. And so I was wondering if you could, what are sort of the top priorities in getting more information or getting better information that helps understand that will help us understand how to build the models that we want, and what are specialists telling you about how they'd like to be measured? Nina,
Yeah.
can we start with you?
Yeah, for sure. I think one of the really crucial maybe they're one building block, but two parts of it. I'm thinking about Legos here, like the little pieces that fit together to make a foursquare. The quality metrics for specialty are tough. Again, like we've got our quality metrics in primary care, that makes sense. We've got a few scattered quality metrics in specialty, like the DMARDs for rheumatoid arthritis, but there aren't, clear-cut often metrics. So complication rates, that's one, but it can be tough. I think the second half of quality metrics is equity metrics, and getting people anyone in medicine, but really getting specialists to engage with collecting data on race and language, race, ethnicity and language, and sexual orientation and gender identity, getting specialists to see that there might be variations in the outcomes or the care that's delivered in those categories, and getting them to engage with that is to learn why. I would say those are really interesting building blocks. They can be tough, quality metrics. When people see their performance on quality metrics at first, it can be really scary for them. But then you can start to engage in conversations about why. There may be one physician in a group who really takes on the complicated cases and helps the group, and they may have higher rates of complications, and that's okay. Women physicians may take on different kinds of patients. Black physicians may have more Black patients, and that's going to be, perhaps a different subset of issues for them to deal with. But we have to be able to start to have these conversations and presenting data to providers and physicians and provider organizations in a respectful way, not to say, we're right, we're going to tell you what to do, we're going to bludgeon you with data. Like, I think, Eric, you said throwing data at them. It's really more like offering with open hands. Here's what we see. This is the numbers that we have. Does this make sense to you? Tell us why and why not. And starting to engage in a conversation so that instead of being enemies, we're actually fighting the problems in the system together.
And for whoever goes next, I want to sort of add the distinction between individual providers and teams, because we're not just talking about what one person is doing, we're talking about what the collective is doing. So what are some of the newer ways that we need to be thinking about that?
Yeah, I can go next. I just want to echo that working with specialists to understand the measures that they feel comfortable being graded on is critical, because unless specialists are excited about this, engaging in value-based care, it is probably never going to work the way that it should work. And so we need to listen and do a lot of uncomfortable conversations and showing data. Like I kind of go on road shows and take some data. Like, one of my friends is a cardiologist, and I was doing some looking at AFib episodes, and I mean, he's, I'm sure, a fantastic cardiologist. He looks really terrible in these set of measures. And so now he's asked me to come give grand rounds to his group, and I'm going to sit there and I'm going to lay it out on the table and talk to them about it. Just yesterday, I was looking at data for an orthopedic surgeon, and he's a trauma surgeon. And when I dig into his data in particular, I think he looks worse than he is, because he's doing like a lot of people that are very injured. And so I think, figuring out how we can accommodate those nuances so that specialists are coming to the table, feeling like it's an environment they want to be in, and that they understand the benefits of why they're doing it, and it doesn't just feel like, I said I can churn out tons of data, I can bury people in data, and I think that success is really going to look like boiling that down into understandable bits, like you said, Lego building blocks. That's what it needs to be. It can't be the Legos either that are 90,000 pieces that you need a magnifying glass to work on. So I think we need to take an extremely complex problem and somehow distill it down into pieces that people understand, because my other passion is provider burnout, and I think that we aren't realizing as a society what's coming our way if we can't ease some of the provider burnout. And then, Mark, I forgot your add-on question during my soliloquy.
Well,
So
I think
I
that was
guess
great.
I'll jump in here and just say I think the successful engagement for us looks like when we go and talk to providers, they don't want to hear about medical trend. They want to hear about how this is going to impact their patients and patient care. So their first question is, will this help me give the best possible care to my patients? How is this model going to interact or impact, how I'm able to interact with my patients, and what their experience is with receiving care from me. And then, they are astute into thinking about how this type of model might impact their core relationships with payers and other providers, particularly referring PCPs. So they're primarily, worried about sustaining and maintaining the viability of their practice. And, there's really a readiness for change aspect too, that practices need to be ready for in order to have productive engagement in value-based care transformation. When we come to practices and say, we've done all this work behind the scenes, and here's the problem we think you're facing every day, we could very well be wrong. And so a good engagement is that providers are nodding their heads and saying, yes, this is something that I deal with every day and it's frustrating, and there's an opportunity here to improve. And when we use data, it's more to say, look, we're validating what you already know to be true because you live it every single day. And then, the providers are excited about the care model that we believe is the solution, or the set of care models, or the combination of care models that could be the solution to the problem we've identified. And in some cases, the providers are already trying to do it in a fee-for-service world, but it's just done at a loss, and just because it's the right thing to do for patients. I think some of the challenges, and Erica and Nina both alluded to it, is some of the timeliness, the transparency, and the clinical validity of the claims data. There's so much nuance and challenge between, porting over financial data onto the clinical experience. And I think really importantly, specialists are really closely watching the experience of providers in models today. And to the extent that models change or are seen as unpredictable or unrealistic targets, or, the actions of either the payer or CMS are seen as arbitrary and unpredictable, creates a lot of hesitancy on the part of the specialist to jump in with both feet to these models. And I think we really underestimate the extent to which, there's good visibility into what's actually happening across the board for these sophisticated practices. So I think it's a really important thing that we all need to be focused on when we're designing and trying to get engagement in these types of models with specialists. So I will say the change from 5 years ago with engaging specialists at Blue Cross to now is night and day. I think in large part to the work that CMS is doing and Duke-Margolis is doing to try to advance a lot of these initiatives. We see specialists being very excited and energized when we talk about value-based care transformation. It's no longer sort of a dirty word within specialty care. We see, similar to primary care, the independents and the community practices are really seeing this as a survival mechanism and a way to compete with the health systems, and even getting a more competitive advantage to other specialists by adopting value-based care models because of the expanding value-based ecosystem in primary care.
Yeah, thanks. And I think to close today, thinking about how much progress we've made in the last 5 years, I want to ask you all in 30 seconds to describe what would success look like 5 years from now Is there a metric or some way that we'll know that like the patient or the provider experience has improved with these specialty models?
I can start.
Oh, go ahead, Erica, you start. I keep starting.
I would say two things. 3 to 5 years from now, I would hope that we have specialists like clamoring to join payment models, because it provides actually better care and simplifies their lives. And on a personal level, like I deal with my mother, like everything I talk about, I think about my mother and what she goes through. And like, I'm really hopeful in 3 to 5 years, she can be involved in some of these payment models as a patient and realize, what coordinated longitudinal specialty bundles actually do to benefit patient experience.
Yeah, I'd say along the same lines, participation by specialists in some sort of outcomes-based payment model is really the norm, not the exception. And I would hope in 3 to 5 years, we have several specialties that have a longitudinal condition or service line based approach across more than one payer. I also would expect the majority of specialties to have at least one option to participate in an episodic type of approach, again, across more than one payer. And then I totally agree. I think it's, ideally we'd see documented cost savings and quality outcomes that are good for patients over that time period. But I also think just having the healthcare system be serving the needs of the patient, as opposed to the reason that it's financed a certain way or reimbursed in a certain way, will be a win for specialty value-based care transformation in 3 to 5 years.
Agreed.
One thing we haven't talked about is multi-payer alignment on these models. I think that would be one real success if we see people starting to align with CMS and commercial payers aligning with each other, so that providers and provider organizations don't have to think differently for different depending on the insurance. But I just want to tap off one thing that Erica said. I actually think success would look like we have a one-to-one correlation of the more penetration we have with specialty and primary value-based models, the less burnout there is. That we have a direct through line that shows that when you pay people to deliver the care that actually matters, that they feel prouder and better about their work, that they're seated in a team, that it doesn't matter what their codes. And one of our questions was about individual codes. That it doesn't matter so much what your individual codes. It's about the care that you produce as a team that influences the life of your patient, and that will directly correlate to reducing burnout.
I think we should just close on that. That's better than anything I have to end this panel. I want to thank you all for joining us today. This has been great. This will continue to be a priority for Duke-Margolis in the coming years, and we're excited to keep working with all of you and and working with everyone who's joined today. I'm struck by all of the energy in the field devoted to making progress in these issues. I mean, this is trying to unwind decades of payment policies and hardwired tendencies, but I think the opportunity is really there to improve patient care and really provide support throughout the care journey in ways that we're not doing today. None of this is happening overnight, but hopefully we've shown today how these foundational elements are working kind of across the healthcare system, and why accountable care models for specialty care will continue getting stronger. I also want to thank CMMI again. I want to thank the Duke team for putting this together. I want to thank West Health for their continued support of us in our accountable care work. And I want to thank you all again for attending, and we'll see you next time.
Take care, everybody.
Thank you.